Hi, my name is Brian Appavu. I am a critical care neurologist at Phoenix Children's, and I have an interest in sort of working on taking care of children with brain injury and advanced neuromonitoring techniques, including transcranial Doppler ultrasound as well as multimodality neurologic monitoring. And we've done work here in regard to transcranial Doppler ultrasound and multimodality neurologic monitoring and ECMO, and so as well as mechanical circulatory support. So I'm going to discuss some of this today. So we're gonna discuss what mechanical circulatory support is, and with kind of an emphasis on extracorporeal membrane oxygenation, and describe how transcranial Doppler ultrasound can be used as a clinical tool for patients on ECMO support. So what's ECMO? What is ECMO? It's extracorporeal membrane oxygenation. Here, we're trying to provide life-saving support to children who are experiencing refractory cardiorespiratory failure. We have sort of two forms of doing this. It's vena-venous ECMO or VV ECMO, and then veno-arterial ECMO. So generally speaking, veno-venous ECMO is going to be used in situations where we have severe respiratory failure. So these may be patients with acute respiratory distress syndrome or just severe respiratory dysfunction. And then VA ECMO will commonly do this in refractory cardiac failure in patients requiring extracorporeal life support, and so forth. So, this diagram is a nice diagram from JAMA Pediatric, sort of just showing like how an ECMO circuit works. The blood pump withdraws venous blood from the child and propels it throughout the ECMO circuit. And sweep gas flows from an oxygen air blender to a membrane lung. And in that membrane lung, blood surrounds hollow fibers as sweep gas, and that's propelled through the fibers, allowing gas exchange within the blood to be able to oxygenate it. When it comes to vena-venous ECMO, you have a dual lumen cannula. It can be placed, reinfused into the right atrium. And then with veno-arterial ECMO therapy, we can do it in a number of different ways in terms of arterial cannulation, and that they can be you can have cannulation that is to the right common carotid, that's centrally cannulated, or to the femoral artery. And the use of where you put the device can actually have a large, where the arterial inflow goes can have implications in terms of perfusion as well as autoregulation and hemodynamics, which we'll talk about. There's studies that show that adverse events are very common in children with ECMO. Seizures, across a number of studies, we see a number of different things. Seizures are fairly common with an incidence of 11 to 23%. This may be because of hemorrhage, stroke, or it could be because of underlying hypoxic ischemic brain injury that may have happened during the ECLS time. We also have intracranial hemorrhage occurs 4 to 16%, and then arterial ischemic stroke, 2 to 17% incidence. So, and a lot of the incidents, the studies that have looked at these have been studies that have evaluated different biomarkers, and that includes studies looking at the clinical exam, plasma biomarkers, neuroimaging, EEG, TCD, and so forth. So we'll get back to ECMO in a little bit. Just for a discussion of mechanical circulatory support, it's also important to talk about ventricular assist devices. We will see these in the CVICU. They are often used. You can't have left ventricular or right ventricular assist devices. These are used in pediatric refractory heart failure when medical therapy is insufficient. Common primary indications are, they're often a bridge to cardiac transplantation when medical therapy is insufficient, but a patient is waiting for a heart transplant. And they can be used in certain situations where, such as myocarditis, if there is a thought that the myocardial dysfunction could be reversed. Risk of brain injury, either from arterial ischemic or intracranial hemorrhage, arterial ischemic stroke or intracranial hemorrhage, seem to be about 10% annually in patients who require a ventricular assist device. So, transcranial Doppler ultrasound, I think you heard about this, so I don't have to go into this in a long discussion. It's it's an ultrasound based on the Doppler shift that allows us to generate echoes and be able to, through an ultrasound probe, and be able to calculate velocities. And when we look at it within the circle of Willis, we're measuring red blood cells and producing a spectral waveform, which we can use to evaluate for cerebral blood flow. When it comes to, I think Virginia and Marina may have alluded to this, but we have a number of studies that have been done, and surveys that have been done, and Delphi surveys that sort of gone over, who does TCDs, and what are sort of our consensus recommendations. This was one of the studies published by Carrie LaRove in 2020, looking at the use of transcranial Doppler ultrasound back then. It's 5 years later, this data probably has evolved, but at the time, 27 centers from the Pediatric Neurological Care Research Group had described that they responded to this survey with, and just to allude here, out of 27 centers that were surveyed, 8 of them were using transcranial Doppler ultrasound for clinical use, and then five centers were using it for research protocols. Now, this study didn't really go into specifics regarding how it was being used specifically for ECMO, although across the board, there was descriptions that TCDs may be used for manipulation of vasoactive agents to target cerebral perfusion, or for discussion regarding neurosurgical interventions, or the necessity of neuroimaging. So I know Marina alluded to some of this in her last talk. We can use transcranial Doppler ultrasound to look at stenosis of a vessel, and this can be really useful in arterial ischemic stroke, and it can also be useful potentially in other situations as well, where there's significant brain injury and impedance of cerebral blood flow, and I'll sort of allude to that. But it's all, the physics of all this is sort of based on Spencer's curve, where we're able to ascertain, using the Bernoulli effect, that at certain diameters of a cerebral blood vessel, there can be from the velocities we can infer changes in volume of flow, as well as when these vessels get very constricted. And from that, I think Marina mentioned the thrombolysis of brain ischemia scores, the TIBI scores, and these sort of get into account that at certain blood flow velocities, whether they're normal, there's focal stenosis, or near occlusion or post-occlusive vasculature, the waveforms change. And so those TIBI scores can be potentially useful, where you can classify waveforms as being absent, minimal, blunted, dampened, stenotic, or normal. And then you can compare side to side and areas, adjacent areas to adjacent areas, to be able to understand cerebral vasculature in a patient. And I'll allude to why this is important in ECMO in a little bit. I mentioned before that, it's right. ECMO cannulation in children can commonly be done in the right carotid artery. This is not done so much in adults, but it's quite common for anybody taking care of children. It's quite common to do arterial cannulation to the right carotid. And I think when I was a neurology resident, I found this like utterly like crazy at the time, because it was like, you're essentially like trying to, you're essentially like cutting off blood supply, from the heart directly through the right carotid to the right hemisphere. And what you're trying to do is you're doing it as a life-saving measure, but you're trying to rely on extracranial as well as cross-collateral flow to be able to provide sufficient circulation to that right hemisphere. However, the risk of injury in these sort of situations is quite high, particularly the right hemisphere. Now, we know with adults with transcranial Doppler ultrasound that we can use a variety of different characteristics to recognize when there is a severe carotid lesion. So you can see some of this in a patient with right carotid cannulation as well, as these patients it's necessary for them to get cross-collateralization. So, some of this can be the side-to-side cross-filling of the anterior communicating artery. There may be reverse flow in the ipsilateral anterior cerebral artery, as well as increased velocity in the contralateral anterior cerebral artery, by up to 25% as compared to the middle cerebral artery. And this can be really helpful for, this is where I know there was a question in the previous talk about when, using transcranial duplex versus, M-mode blind TCD. This is actually this is definitely where duplex imaging is going to be to your advantage because you're looking for you want to pick the right vessels to look for that reversal of ipsilateral ACA, or when you're looking at the ACE comparing ACA MCA velocities and potentially reverse velocities, that you're capturing the right vessel. The other thing is, your posterior cerebral arteries will be faster than your middle cerebral arteries because you're trying to promote um, collateral flow from the posterior circulation up to the anterior in the setting of a cerebral carotid lesion. So again, duplex imaging can be really helpful in these sort of situations to be able to get at when the flow whether you have the collateral flow you want when you are cannulated on the right carotid artery of an ECMO patient. And then you can have reverse thalamic artery as well in these sort of situations. So these are all things that can be helpful in terms of ascertaining an assessment of cerebral blood flow in a patient on ECMO, particularly those that are undergoing right carotid cannulation. We did a study. We had a study funded by the American Heart Association that we conducted from, I think it was like 2019 to 2022 or so. We got it published in Neurocritical Care in last year. So we prospectively enrolled children on ECMO and underwent multimodality neurologic monitoring. So as part of this, all patients had underwent continuous EEG. They underwent continuous NIRS. We used a multimodal monitoring device, the Moberg CNS monitor, as a device to integrate all this data together. And we had all the patients also get daily transcranial Doppler ultrasounds. For the most part, we got them daily. There were certainly times where the days we missed getting them done, but we were having them done with vessel installation to the middle cerebral arteries. And we as part of this we tried to develop a multivariable logistic regression model to see which patients what neuromonitoring biomarkers across multimodality monitoring, whether it be markers of autoregulation, EEG markers, NIRS markers, TCD markers, what provided us the most accurate model of predicting brain injury. So we were able to develop a model with pretty high accuracy, with an area under the receiving or operating curve of 0.92, where there are three independent variables that predicted brain injury, and that is from EEG we had hourly seizure burden as well as quantitative EEG amplitude asymmetry differences. Those were independently predicted. But the other thing we found was that if you estimated the TIBI score, the thrombolysis and ischemia brain injury scores of the middle cerebral arteries, the left and the right, and you compare the two, and you looked at the difference between the two, that difference was independently predictive of a patient having a brain injury. So you think of a patient with a normal waveform on the left MCA, a dampened or blunted waveform in the right MCA. That's a patient who has a marker that is independently predictive of brain injury in our study. So to my knowledge, our study was the first one to show a real a strong statistical signal of a TCD biomarker to brain injury in pediatric ECMO. There have been other studies to date that have described a trend for velocities or pulsatility indices toward an injury. We did not see statistical significance with any specific flow velocities or PIs. I think ECMO is extremely dynamic. Changes in sweep, blood pressure, pulsatility. It just changes all the time for these patients. However, if you look at the TIBI scores, if you focus on that, and that hasn't been focused in other pediatric studies because it comes out of adult data, but if you do measure the TIBI scores for these patients, we found a statistical significance with a pretty good p-value, with pretty high odds ratio, and independent when you even accounted for markers like EEG and things from the NIRS. So this is what we found. We recently updated our neuromonitoring pathway at our institution in terms of ECMO, where we include, we do things. The ELSO has produced some recommendations recently on neuromonitoring for pediatric ECMO patients, and that their guidelines came out around the same time as our study, so they did not account for our study. But they had recommended continuous EEG as well as cerebral nears, which we use. There's some data suggesting a decline in cerebral nears by greater than 20% is associated with brain injury. And I think with our study, we also sort of advocated for the use of TCDs. If you look at the ELSO guidelines, they do say that, which came out around the same time as our study. They said that there's not enough data to to reliably use TCD as a monitor for predicting brain injury, but I don't think they had all the studies that were that available at that time. So what we do is we do what they recommend. We got EEG, we got NIRS, we also add pupillometry, and we also do daily TCDs for the first 3 days, and then after that we kind of do it as needed. But what we do is, if we, as part of our protocol, we look at, are there signs of brain injury? So EEG, seizures, asymmetry on the EEG, waveform asymmetry, decline in NIRS, and if we do see that, we implement a couple different things. And then number one is that we start neuroprotective measures. So we act as though the patient has a brain injury. So we make sure that we target their sodium to be greater than 140. We make sure that their we do what we can to target good perfusion. We make sure that they avoid hyperthermia, and then as depending on the VA or VV situation, we may target PaO2 and PaCO2 targets. That's a lot harder with VV ECMO patients and patients with cyanotic disease in the CVICU. But if feasible, we'll try to implement those and tailor them to the patient. We treat seizures, and then we make sure in this situation that we're going to have a multidisciplinary meeting. So if there's signs of brain injury, when we round, it's a multidisciplinary round with neurocritical care, critical care, surgery, palliative care. Palliative care is sees all of our ECMO patients as standard of care. And we talk about, we have a discussion about a number of different things, and that is like, okay, is this patient safe for imaging? Yes, no, how can we do so? And if not, what do we do about that? We also have discussion about ECMO decannulation. What would happen if this patient had an intracranial hemorrhage and that would cause impending herniation and could benefit from a decompressive craniectomy, but you would need to decannulate in that situation. Like, can you actually do that? Can you decannulate? Would this patient survive? We certainly have patients who we've done emergent decannulations for who have survived. There's a lot that don't. What we do is we start that discussion. We start that discussion the moment there's a biomarker telling us that there's a brain injury. So we are ahead of the game. So, we can't save every patient who has a brain injury on ECMO, but if we can catch the few, the handful a year that you might, by altering your neuroprotection or, decannulating at the right time and leading to another intervention, you're able to catch those situations. So that's what we've done. So with that, I want to go over, maybe with a few minutes, just a couple cases of different things. And I think Marina had presented some good cases, and some of this I'll go over. This was a case of a patient with a mechanical circulatory device. The first year the first year that I was actually, this was the first week I was on service as a new attending. This was a 5-year-old girl with hypoplastic left heart syndrome who had who woke up with a facial droop. I think the patient was on a lot of vasoactive agents and was unstable. The team really did not want to move the patient if at all possible, but they recognized there were new neurologic signs involved. I think in all our guidelines, if there's a stroke or concern of a stroke, we say, go emergently to imaging. I think in the CVICU, when you got these complex patients on multiple drips, it's like, you have to do some convincing in those sort of situations. Anyhow, in this patient, we looked at the waveforms from side to side. Now cardiac CVICU patients with congenital heart disease, their waveforms are going to be very abnormal. But you can see here on the right middle cerebral artery, she's got flow velocity of 46, a PI of 1.45. You can see pretty hot, good a good systolic acceleration here, and a good and good vasomotor reactivity with the dicrotic notch. But then when you look at the other side, there's lower flow. The waveforms seem more blunted on the left MCA. So we definitely felt like there was something arterially different between the two sides, and we pushed for neuroimaging. We saw an M1 occlusion, and we were able to go for a thrombectomy for this patient. Just another example. This is a child on ECMO, and this was a patient we were not able to get emergent imaging. But on the left MCA, we were doing routine TCDs. On the left MCA, we had a nice flow velocity of 65.1 with a PI of 1.55. This is a patient on VA ECMO, right carotid cannulated, and then you got a good dicrotic notch here, a good systolic upstroke, and then when you look at the right MCA, you have a delayed systolic upstroke, no dicrotic notch, and a lower PI. And this patient, ended up having an M1 occlusion. Now, this patient was one where we picked this up after imaging. Their EEG actually looked okay. It wasn't dramatic. So, yeah, and this patient actually was able to get decannulated, survive, and has some left-sided weakness, but is otherwise doing well. I showed you a couple TC. Yeah, so just for the sake of time, I'm going to skip some of these cases. This is, I wouldn't advocate that you necessarily do this routinely, but I wanted to show you just a case example of multimodality monitoring of how dynamic, what's possible with TCDs, neuromonitoring, and ECMO. So this was a 14-year-old girl on VV ECMO with acute respiratory distress syndrome. Her EEG was a little slow, which could have been sedation and whatnot. And we were doing continuous TCDs on her, and we noticed that her, for her age and her flow velocities were on the lower end at 47 centimeters a second. PIs were on the higher end above 1.3. So, I think you can commonly see this in VV ECMO patients but there's some signs of some cerebrovascular resistance here, and her PaCO2 was on the lower end. So we discussed some of the findings with our critical care team, and I think there was an agreement to try to see if we could adjust her PaCO2 target a little bit. And here's where we changed her ECMO sweep settings from 3 to 2 liters. And when we did that, you had a really nice rise here in the cerebral nears, and her flow velocities went up and pulsatility indices went down. So you can see how dynamic some of these changes can be. So, you're changing flow and oxygenation in the brain. You're increasing flow and oxygenation just with just with that little ECMO sweep change, that setting that you have. So this stuff is extremely dynamic. Now, how to do this in real, this was like a one-time situation where we did this. I wouldn't advocate for doing this routinely. I think you want to be very nuanced if you want to tailor care like this. But I show this just to give you kind of an example of how dynamic we can look at changes in oxygenation and blood flow related to the ECMO settings. And I think there are very large knowledge gaps about how to use some of the ECMO settings to optimize neuroprotection in children on ECMO. We know that ARDS has a high risk of brain injury and neurodevelopmental sequelae. We know that hypoxic ischemic brain injury is common in ECMO. So, ways that we can use this information to optimize care, lots of knowledge gaps. And there's other things crazy things that we see. I don't have an explanation for this. I just want to show you to this just so you have an understanding of what can happen on kids on ECMO. So this was another patient that we did transfield Doppler ultrasound here to the bilateral middle cerebral artery flow velocities. The top row is the left middle cerebral artery flow velocities, and the bottom row and the second to top row on the red is the right middle cerebral artery flow velocity. And then the RSO2 is the nears, and then I got the patient's blood pressure. And this was a patient who was just acting, just was on ECMO, was on minimal sedation, but was just altered. And you can see here, and they were just having fluctuant blood pressure, actually very cyclical blood pressure fluctuations that our cardiac ICU was not able to explain. And I still don't have an explanation for it. But what was fascinating about this case was if you look at the flow velocity on the right and left side. So this was a patient who was right carotid cannulated. And you can see that this patient's like their flow is going the opposite direction. So when their blood pressure spikes up, their flow velocities on the left drop and their flow velocities on the right go up. And then as blood pressure drops suddenly, then the flow starts to rise on the left side and drops on the right side. So, I don't know how common this is. And I still, I monitored this kid maybe 3 or 4 years ago. I have no explanation for what I'm seeing here. But I bring that up just because it's a knowledge gap. Like blood flow is dynamically changing in ECMO patients. And TCDs allow us to get some insights into what is actually happening. We know that brain injury is common. We know that neuropsychological impairments and long-term outcomes are limited in survivors, and even survivors end up having migraines and neurologic sequelae, increased risk of TIAs. We're completely changing vasculature, and TCDs allow us to get a little bit of insight as to what is going on during that time. So, I think there's just a lot of knowledge gaps that we have. So, yeah, in conclusion, mechanical circulatory support provides life-saving support to children with refractory cardiopulmonary failure. TCDs allow for an assessment of cerebral blood flow. You can use MCA waveforms and look at their asymmetry as a way to assess for risk of brain injury. We showed that it was independently associated with brain injury, and they may be helpful in optimizing neuroprotection measures for children on mechanical circulatory support with a lot of knowledge gaps and research opportunities moving forward.